Hello everyone, Professor Baig here. Today we're going to explore the pathophysiology of cancer, beginning at the cellular level and connecting it to the clinical manifestations, diagnosis, staging, metastasis, and treatment. As we go through this lesson, try to focus on how abnormal cellular changes eventually lead to systemic disease. Along with this recording, also please read the assigned ratings in your module and complete your study guide as you're watching this. Cancer remains one of the leading causes of death in the United States. Although incidence and mortality rates have been declining because of improved screening and treatment, millions of people still continue to be diagnosed each year. Most cancers occur after the age of 55, but cancer can develop at any age. Cancer patterns differ between men and women. Men generally have higher overall cancer mortality, while prostate cancer is the most common in men. In women, breast cancer has the highest incidence, but lung cancer remains the leading cause of cancer-related death. Now let's talk about what cancer actually is. Cancer or neoplasia refers to uncontrolled cell growth. Now normally cells divide only when needed, but cancer cells continue reproducing even when there is no physiological purpose. The uncontrolled growth compresses surrounding tissues, reduces blood flow, and eventually leads to tissue death and organ dysfunction. Cancer development is driven by two major dysfunctions, defective proliferation and defective differentiation. Now, normal cells follow an orderly process of maturation and perform specific functions. Cancer cells, on the other hand, lose contact inhibition, growing over and between normal cells in what we call the pyramid effect. This rebellion involves a behavioral shift where cells disregard growth inhibition signals and bypass critical checkpoints in the cell cycle. At the genetic level, this is often a result of mutations in the proto-oncogenes or tumor suppressor genes. First, let's look at cell proliferation or growth. In normal cells, growth is tightly regulated. They exhibit something called contact inhibition, which means they recognize the boundaries of neighboring cells and stop growing once they come into contact. Cancer cells, however, lose this ability. They continue to grow uncontrollably, piling on top of each other and invading spaces between normal cells without regard for boundaries. Normal cells grow and develop in a very organized and controlled way. They differentiate through an orderly process, progressing from an immature state to full maturity. As they mature, they take on specific roles and functions that support the body. Once differentiated, these cells are stable and do not revert back to an immature form. However, with cancer cells, on the other side, they behave differently, right? They lose contact inhibition, meaning they no longer respect the boundaries of neighboring cells. Instead, they grow over and between normal cells, disrupting normal tissue structure. This growth is uncontrolled as they ignore the regulatory signals that typically limit cell division. This causes rapid and excessive proliferation, often described as a pyramid effect, where more and more cells are produced at an accelerating rate. Also, cancer cells tend to have a shortened doubling time, which refers to how quickly a tumor can double in size. This further contributes to their excessive growth. Just to reiterate, cancer cells are defined by the behavioral shift. They disregard growth inhibition signals and bypass checkpoints that normally regulate the cell cycle. Normal cells pause at checkpoints for DNA repair or enter a resting phase. Malignant cells do not stop. Instead, they rapidly reproduce, growing on top of and around other cells until they eventually break free from their tissue of origin. So I just kind of wanted to reiterate that so you can remember. Now we'll just briefly touch on the genetic involvement. We're not going to go deep into this topic. It's a whole different lecture. So let's just briefly go over it. Now, cancer develops because of mutations in genes that regulate growth and differentiation. Two major gene groups involved are proto-oncogenes, which promote growth, and tumor suppressor genes, which may normally slow or stop growth. Examples of this are the BRCA1 and BRCA2, for example, that you see in breast and ovarian cancer. You have the APC, which you see in colorectal cancer, and the P53, which is mutated in many cancers such as breast, lung, and colon cancer. So how do these genes mutate? Mutations may be inherited or acquired. Most cancers result from acquired mutations caused by environmental exposures or aging. If damaged cells fail to repair themselves or undergo apoptosis, the mutation is passed to future daughter cells. This diagram over here demonstrates the stages of cancer development. A normal cell becomes altered after exposure to carcinogens. It progresses through abnormal proliferation and eventually develops into clinically evident cancer with possible metastasis. Carcinogenesis occurs in 3 stages: initiation, promotion, and progression. So initiation involves irreversible DNA mutation. Promotion stimulates the growth of those abnormal cells, and progression leads to the aggressive invasive cancer. Let's talk about tumor angiogenesis. This is the final phase of progression. As tumors grow, they require their own blood supply. Cancer cells release the VEGF, which stimulates angiogenesis, or new blood vessel formation. So basically, they're creating their own blood supply because remember, they want to overgrow, they want to invade. And so in order to do that, they still need blood supply to do this. So this provides oxygen and the nutrients they need to continue the tumor growth and metastasis. Carcinogens are agents that damage DNA and increase cancer risk. These include chemicals like benzene, radiation such as UV exposure, oncogenic viruses like HPV and hepatitis B. Many factors can increase cancer risk. So let's talk about these risk factors. These include aging, tobacco use, obesity, genetics, radiation exposure, viral infections, and immunosuppression. Tobacco remains one of the largest preventable causes of cancer. Now let's talk about the difference between benign versus malignant neoplasms. Benign tumors are usually encapsulated and remain localized, so they stay in one spot. Although they do not metastasize, they can still cause problems if they compress vital organs or structures. So they basically are not metastasizing, but they are overgrowing and compressing, causing compression on the vital organs or structures around them. Malignant tumors contain dysplastic cells that grow rapidly and invade surrounding tissue. They often have abnormal chromosomes, altered cell membranes, and disrupt communication between cells. This slide over here highlights several important concepts and topics of malignant tumors, including rapid spread, altered DNA, enzyme secretion, and loss of growth inhibition. These characteristics are important for you to remember as you study about cancer. And so I basically created a cheat sheet so you can look at these. Tumor names are often based on the tissue of origin. Benign tumors often end in oma, while malignant epithelial tumors are called carcinomas, and connective tissue cancers are called sarcomas. So basically, this is the language of the tumors. If you look over here, like adenoma, These are the root words. And when it becomes malignant, it's called adenocarcinoma. Fibroma, fibrous tissue, that's the origin. And then when it becomes malignant, it's fibrosarcoma. Same thing with osteoma, right? It originates in the bone, the osteo, and if it becomes malignant, it's osteocarcinoma. This chart provides examples of tumor naming conventions. Nomenclature means naming of something, and nomenclature of neoplasms is basically naming of the different types of neoplasms. So this over here, it's based on tissue type, just to reiterate, such as lipoma versus liposarcoma. So when you hear sarcoma, then you know it's malignant. Or adenoma versus adenocarcinoma. Now, let's talk about the effects of cancer. Cancer affects the body both locally and systemically. Tumors can compress tissues and blood vessels locally, while systemic effects include fatigue, cachexia, anemia, and endocrine disturbances. Cancer's clinical toll is both, as we mentioned, local and systemic. Locally, a mass can cause obstruction of ducts, tissue necrosis, leading to infection and pain in late stages. Systemically, patients may suffer from cancer cachexia, which means severe tissue wasting, driven by altered metabolism, and anemia from chronic bleeding or bone marrow depression. Some cancers even cause paraneoplastic syndrome, where tumors secrete hormones like ACTH, triggering unexpected pathologies. Malignant tumors increase the pressure on the surrounding tissues and blood vessels, causing inflammation, necrosis, organ dysfunction. Patients often experience fatigue, weight loss, infection risk, and bleeding. Now let's talk a little bit about the paraneoplastic syndrome. The paraneoplastic syndromes are effects caused by tumor-secreted hormones or chemicals rather than the tumor mass itself. So it's basically caused by the hormones that are secreted by that tumor. So these syndromes may actually be the first sign of cancer. Now let's talk about metastasis. Metastasis occurs in 7 steps. Through a series of steps, basically, there's 7, beginning with the invasion and ending with secondary tumor growth. Cancer cells enter blood or lymph vessels, and once anything enters the blood, then it's going to circulate. Same thing with lymph vessels. Now they travel throughout the body, adapt to new environments, and establish new tumors. And this is how it spreads. So basically, the 7 steps are invasion, where the tumor invades the nearby tissue, intravasation, where it enters the blood or lymph, circulation, where it travels through the body, adhesion attaches to the new site, extravasation, where it exits the vessel, adaptation, survives to the new environment, and finally growth, where it forms a secondary tumor. Cancer cells, as you can see, are extremely smart. They create their own blood supply and they know how to grow. Cancer exploits the body's transport system to spread local invasion, involving secreting enzymes like collagenase to break down adjacent tissue. Cells may travel through the lymphatic channels to regional nodes or spread hematogenously through the bloodstream to lodge in capillary beds in the liver, lungs, bone, or brain. A third method, seeding, involves the dispersion of these cells within the major body cavities, such as the peritoneal cavity, for example, in ovarian cancer. Now, the biggest way to treat cancer, honestly, is prevention, right? Now let's talk about prevention and treatment. This section transitions us basically from understanding how cancer develops into prevention, diagnosis, staging, and treatment strategies. Diagnostics establish the severity of the disease. Grading occurs at the cellular level, measuring the differentiation from grade 1, which resembles normal tissue, to grade 4, where it's highly aggressive anaplastic. Staging uses the T&M system. T is the size of the primary tumor, N is the regional lymph node involvement, and M, distant metastasis. While biomarkers like PSA or CA-125 help monitor progressions, biopsies remain the only definitive test for malignancy. The TNM system, it evaluates the tumor size, lymph node involvement, and distant metastasis. Staging helps determine prognosis and guides the treatment plan. So basically, the TNM system is the cellular level, where it basically you're trying to understand how, the stage of the cell. Grading actually helps, with the treatment strategies. Low-grade tumors look more like normal tissue and generally grow slowly. High-grade tumors are poorly differentiated, aggressive, and more likely to spread rapidly. Over here, if you look on this PowerPoint, there are the grades 1 through 4 with the key points for each. Cancer diagnosis involves multiple tools, including blood tests, tumor markers, imaging studies, and biopsies. Biopsy remains the gold standard for confirming malignancies. And over here in this chart, I've provided the different blood tests that you usually see, the tumor markers, imaging, and the biopsy and cell studies. All the key points right here. Treatment combines local and systemic approaches with either curative or palliative intent. Surgery and radiation target local areas. So if the tumor has not metastasized a lot, you can use radiation to basically target that area. So radiation specifically causing lethal mutations to prevent mitosis. That's what the radiation is used for, to target the local areas. Chemotherapy uses systemic drugs designed to interrupt specific cell cycle phases, such as the S phase, the DNA synthesis, or the M phase, which is mitosis. Now, hormonal and targeted therapies further assist by blocking growth receptors or starving tumors of new blood vessels, because remember, they create their own blood supply. And so the hormonal and targeted therapies help, starve these tumors so they cannot create their own blood supplies or not benefit from these. So you have surgery and radiation for local areas, chemotherapy for which is systemic drugs, and hormonal and targeted therapies. Treatment goals could be curative, to cure the cancer, palliative, or prophylactic, depending on the tumor stage, spread, and the patient's condition. So basically, curative is for small localized tumors, palliative is for advanced cancer, is basically to relieve symptoms, symptomatic treatment, and improve the quality of life. Prophylactic is preventative, is to prevent cancer in high-risk patients, for example, people with the genes, or prevent reoccurrence. What are the treatment options? Like we mentioned before, surgery has the highest cure rate for solid, well-circumscribed tumors. Radiation uses ionizing radiation to destroy rapidly dividing cells. Chemotherapy uses cytotoxic drugs that target the cell cycle. Then you have immunotherapy that enhances the body's own immune system to attack cancer antigens or inhibit the T cell deactivation. Surgery, antineoplastic drugs, chemotherapy drugs that kill or slow cancer cells. Basically, they disrupt DNA replication, protein synthesis, inhibit microtubules, which blocks cell division. Because remember, we mentioned earlier that cells just abnormally overgrow. So this basically inhibits that. The systemic effect for these antineoplastic drugs is that they travel through the bloodstream and they treat metastatic cancer. Biological response modulators. Those are another type of drugs. These therapies boost the immune system to fight the cancer. Surgery is often the most effective for localized tumors. Radiation damages the DNA in rapidly dividing cells, and chemotherapy targets the cell cycle. Immunotherapy, like we mentioned, activates the body's immune response against the cancer. Managing these adverse effects of systemic toxicity. A major challenge is that radiation and chemotherapy damage all rapidly dividing cells, not just cancer cells. The limiting factor is often bone marrow depression, resulting in leukopenia, which is basically low white blood cell count, extremely low white blood cell count. This becomes then infection risk. Then you have thrombocytopenia, where you have a huge bleeding risk, and anemia. Patients also face epithelial damage such as alopecia, hair loss, and stomatitis, mouth ulcers, as well as potential sterility and intense psychological anxiety. Now, hair and skin cells grow rapidly, and a lot of these treatments target rapidly growing cells, and that's the reason why a lot of cancer patients tend to have alopecia, hair loss, or damaged skin because of the rapid skin being a rapidly growing cells. Cancer prevention. These are basically ways that people can prevent cancer, right? You have basically avoiding tobacco, limiting alcohol, maintaining a healthy weight, staying active, getting adequate rest, getting regular checkups, getting regular screenings, know your history, be familiar with your genetics, basically protect your skin from UV rays, and managing stress. So these are all ways of preventing, the risk of cancer. Now let's talk about the early warning signs, that require clinical investigation. So basically they rely on investigating 7 warning signs summarized by the caution mnemonic. So this is an easy way of remembering this. C stands for changes in bowel or bladder habits. A stands for a sore throat that does not heal. It's on the, a sore, that does not heal on the skin or in the mouth. And U for unusual bleeding or discharge anywhere in the body. Any unusual bleeding. T for thickening or lump in the breast, testis, or elsewhere. I for indigestion or difficulty swallowing. O, obvious change in wart or mole, color, size, or shape. N for nagging cough or hoarseness without any reason. So these are some 7 early warning signs that we should always encourage our patients to contact the provider for. Effective cancer care requires an integrated ecosystem. This includes prevention by altering epigenetic factors and avoiding carcinogens, surveillance through biomarkers and recognizing caution signs, precision intervention using the TNM stage to deploy surgery or chemotherapy, whichever is needed, and managing the patient's ecosystem by balancing aggressive treatment with palliative and nutritional support. This concludes our lesson on cancer pathophysiology. Please complete your assigned ratings in your module and complete your study guide. This will help you to remember all the important key points for this lecture.